Welcome to the Alphagenix Podcast, where every week we talk to incredible guests from around the world of biohacking, well-being, men's health, and more. Here's your host, co-founder of Alphagenix, Ross Tomkins.
Well, I'm absolutely delighted to welcome today's guest. We have Dr. Andrew Winge and, of course, our very own Dr. Max Draper. Welcome, guys. I'm really excited about today's episode.
Yeah, thank you for having me. I appreciate the invitation.
Absolutely, yeah. Thanks.
So today we talked a little bit off camera before then. We talked about, going a little deeper into the science behind hormone optimization. So I'm going to hand over to Max and Andrew. If you guys go as deep as you want on this subject, I think it'd be great to get that value out there. And to all of the listeners, I guess, what is hormone optimization? Why is it important? And some of the questions that we get asked a lot in our little communities to do with SARMs as well. So I'd love to get your input on that as well. But yeah, I'm going to stay out of the way. Over to you guys.
Yeah, I'd just say it's a pleasure to be on with Dr. Winge, because his Man Medicine channel is something that I've followed for, has it been about 3 years it's been up and running now, roughly?
It feels like 3 years, but it's been just over a year.
What? Oh, really?
Yeah, I'm just getting started. I'm just getting warmed up.
Oh, right. Fair enough. So if people watching who haven't seen it, it's a very useful site in terms of going into deep dive scientific sort of the research behind a lot of what we hear online, and actually just, I would say, not necessarily, well, maybe correcting, but actually saying what is actually the underlying science to a lot of what you hear out there. What I would start just saying, what sort of inspired you to create that channel? Was that the sort of idea behind it? Was actually putting the real science behind what you hear online, perhaps?
Yeah, absolutely. Yeah, absolutely. I'm a conventionally trained MD. I'm boarded in family medicine and emergency medicine, and I worked in academic medicine for a long time. So I've always had a bit of an evidence-based bent to it. But I've been interested in, not just hormone optimization, but health optimization and longevity for a really, really long time. And, as you know, and we've talked about offline, I mean, when you go online and you go to forums and you try to find good information on, protocols and, what's the evidence base for many of the things that are recommended out there, it's a little sparse. And there's some voices out there that are saying things that may or may not be the most evidence-based recommendations. It's not that perhaps they don't work, it's just that maybe there isn't evidence for them. But there's also some people out there saying things that, in my opinion, can be somewhat harmful. So, rather than just reading these forums and getting mad and getting frustrated about it, I thought, why don't I not only for my own education but for others as well, start looking into this research, start putting it out there in a medium that is easy to for people to understand and to access, like YouTube, and see what happens with it. And it's been great. It's the responses that I've gotten have been overwhelmingly positive, despite the channel being, fairly new and fairly small. Some of the best parts is I've had men from all over the world reach out to me and speak with me, ask me questions, do consultations. It's from South America, Australia, Asia. So it's been great. It's opened up a lot of doors for me to communicate with men. And, the thing that, I think I always knew this, but it really drove the point home that this is an issue for men all over the world. It's not just in North America. It's not just in the UK. There are people in the Middle East and, like I said, in Southeast Asia, everywhere all over the world that are struggling with the same issues that all of us are here in the Western world. So yeah, basically, there's a lot of bro science out there, and I wanted to bring a little bit of a higher level, more evidence-based flavor to some of the information that's out there. And I know it's a drop in the bucket. My little voice is sort of drowned out by thousands and thousands of others out there, but it's just my little contribution to this whole endeavor is to try to keep things as evidence-based as possible, which can be challenging because a lot of stuff is just there's not a lot of interest in the research world in testosterone and in peptides, and of course in SARMs too. We'll get to SARMs. So, but there is some, and I think that needs to be put out there for people's information, and not just the layperson, but providers too.
Yeah, we have to kind of go off what research we have with the sort of with the biology as well, don't we? Really, it's not like you have
absolutely.
A million papers on it. Yeah,
right. Yeah, and a lot of stuff that we do, maybe there's a logical biological plausibility for what we do, but I might not be able to give you 200 evidence-based randomized trials to show you exactly that this is 100% going to work. And so that's where it comes down to communicating with the patients. And when I consent a man for something just as simple as testosterone, that is not a short conversation, a long conversation. It's one of the things I like about my little private practice is I get to take the time to talk to men. And Max, I know you were in primary care for a long time. I know when I had 15 to 20 minutes to spend with a patient at the most.
Yeah.
And it's 10, just impossible.
10.
You can't, if you're lucky, 10 is more realistic.
Yeah.
But you can't give good care in 10 minutes. I don't care how great a clinician you are, how good your support staff is. It just can't be done, in my opinion. So,
yeah. It's. I mean, that's where we were talking on a previous episode about this issue we have with sort of not. I wouldn't like to use the word overprescribing, but perhaps the idea of giving someone a prescription kind of, that's the end point of the consultation, isn't it? Yeah. And if you've got 10 minutes, you've got 20 people in your clinic.
Right.
Yeah. Right. It's hard to delve into the nuance of an individual situation and actually talk about lifestyle, even hormones.
Absolutely.
I take hormones as kind of separate to a lot of medication because it is kind of foundational, bioidentical, kind of is separate in a way. I suppose I hold it separately.
Well, and then of course, in the primary care world, there's no education for doctors, and even in basic, conventional hormone replacement. I had 0 lectures in 4 years of medical school and 6 years of residency on how to prescribe testosterone. Not one single lecture on testosterone. If it was even mentioned at all, it was like, oh, that's steroids, that's bad. You're going to give your patient prostate cancer and a heart attack. It's so, I hear people on the forums, and I completely understand, and they complain about their primary care doctors, and they don't, they're idiots, they don't know anything about hormones. And I stick my head into those conversations sometimes, and I say, listen, that's not their fault. They're there to manage your heart failure and your chronic kidney disease if they can. They're not trained to, it's not a reasonable expectation to expect your GP, or in some cases, even your endocrinologist, to understand health optimization. So they can make you sort of not sick, but they don't know how to take you from not sick to optimally healthy, which is, that's what I'm interested in for myself. And that's what I'm interested in for my patients, obviously.
Yeah, it's slightly different in the States now, is it? I suppose there's more use of testosterone, I guess, is that the right terminology?
Yeah. There is. And for me, it's a bit of a double-edged sword, because we do have, oh my gosh, there's a TRT clinic on every corner now. The concern I have is the quality of the care that these guys are getting. So access is not the biggest issue right now. It used to be, but it's the quality of the care. Here, I live in a relatively small city. There's at least 2 of what I call windmill TRT clinics here. They're not run by physicians, and everybody gets their cookie cutter 200 milligrams of testosterone cypionate, 1 milligram of Arimidex, and thank you for your monthly payment. And and very little else, and that's not ideal. Obviously, that's not ideal. So I do have concerns that eventually our FDA and these other regulatory bodies are going to start. There's going to be a little bit more scrutiny, and it's going to make things more difficult for the rest of us that try to do things in an evidence-based manner and try to be judicious and take the time to do things appropriately, it's going to make things more difficult. Right now, we're not there yet, but they recently have passed some legislation with peptides. So I was kind of worried, like, well, what's next, after peptides? And it's that old phrase about, one bad apple ruins the whole barrel. We unfortunately have a lot of these just windmill, that's what I call them, windmill TRT clinics, where they're just running guys through. They're charging them $200 or $300 a month, and everybody gets the same protocol. They're not being monitored properly. They're all having their ferritins crashed because they're being forced to donate blood, and their estradiol is all in, they're all in the undetectable range. Yeah. And anyway, so there is access, but again, the quality of the care, you have to sort of do your due diligence, I think, as a patient, which is hard. If you don't have a medical background and you have somebody there in a white coat with a stethoscope, we tend to defer to those people as experts, but many of them are not. Mm-hmm. Mm-hmm. It's just the way it is.
Yeah. So it's business by numbers, isn't it? Almost in this.
Absolutely.
It seems to be the opinion I get from people. Yeah. Out in the States. Yeah. Yeah.
And I wish these clinics would understand. I mean, the best business model is to take really good care of your patients.
Yeah.
Even in the UK, we get that, where people feel like just a number because they're not being listened to. It's not individualized care.
Yeah.
They're not running the labs on a regular basis and actually giving something specific. It's just, as you say, okay, I'll sign you off, just have X, Y, and Z. What everybody
gets. It's frustrating, and I understand. It is the way it is. But you said something really important, Ross, about listening to your patients. As a provider, especially in this health optimization space, because as we all know, I mean, the symptoms of suboptimal testosterone are nonspecific. Not everything is a testosterone problem, obviously, and sometimes as you start to scratch under the surface and peel that onion, you discover all these other things that maybe the patient was a little bit reluctant to share with you, issues with their relationship and their lifestyle and stuff like that. And that really is where the problem is. But those things never get addressed, not only in the primary care clinics, but even in some of these high volume TRT clinics. They just throw testosterone at everything. So they say, wait, when the only thing you have is a hammer, then everything looks like a nail. So, which is not to take away from the fact that, I mean, we all know that testosterone can be fantastic. I mean, I know it was life-changing for me. Mm-hmm. I'm sure both of you probably have had positive experiences with it, or else you wouldn't be here. But it can be absolutely amazing, but it's important to keep it in context.
Yeah, it changed my career route, so it was pretty big deal. Yeah.
Yeah, me too.
Yeah,
absolutely. Yeah, I still work in the emergency department. I still like critical care, and I like taking care of really, really sick people. But as time goes on, I'm just more interested in the prevention and longevity part of things. So as I get older, I've turned 50, so now I'm just going to slowly start transitioning out of working in the emergency department and eventually start doing this a little bit more full time, because it is more rewarding in the long run for me.
How is it doing that? Sorry, Ross. How is it doing that combination of work? Because I've always, when I watch your stuff, I always find it interesting that you do. Basically, it's almost like two ends of the spectrum, isn't it?
Yeah.
It's the emergency side of it, and then the preventative side of it. Mm-hmm. And I suppose the question as well is, how often do you see things come in the emergency department bit, and you think, if I got my hands on you 10 years ago,
every day,
every day,
every day. Yeah, I jokingly say that my overall, like my whole medical practice is very bipolar. So, I think of health on a spectrum. Like if we look at it as a bell curve, on the far left, I have these just incredibly sick, chronically ill, morbidly obese, individuals that they come in, on death's door in the emergency department. And I try to move them a little bit further to the right, keep them from falling off that curve. And that's what I do in the emergency department. And then obviously, I still get some chronically ill men in my health, my men's health practice, but I generally have men that are further to the right side of the curve, and they just want to go all the way to the far right as they can. And so, but I don't get very much in the middle. I just don't. That's just the way it is. So yeah, I tend to be on two ends of the spectrum. But Max, you're absolutely right. I mean, almost everything other than, you know, the traumatic injuries, which, you know, the accidents, obviously, that come in, you know, all of this stuff that I see is entirely preventable. And, you know, I imagine it's not terribly different in the UK, but I've noticed a trend in medicine, and the patients are getting sicker and sicker and sicker at a given age. And it's become interesting as I've gotten older, you know, going through my 40s, and now as I'm entering my 50s, I'm seeing men that are roughly in the same age group as I am, and they're coming in with massive heart attacks, and I'm sending them to the operating room to get their feet amputated, and all of these chronic medical issues that, again, are entirely avoidable, and they're in my age demographic. And I sort of look at them, and I look at myself, and I think, you know, what somewhere we've diverged, you know. When was that point? And, you know, it's tragic in a lot of ways, because, you know, those men, they could have been helped 20 years prior. But, you know, not to be too black pilled about the whole thing, but so many of these people, they're just not interested. I have a really hard time in the emergency department convincing people, even in the middle of a COPD exacerbation, to maybe consider quitting smoking. You know, I've had patients file complaints with the hospital because I advise that they lose weight to get their blood sugar of 350 under control. And of course, you know, I do things that are very nice and very professional, but many people are just not open to that. And they think, well, how dare you, you know, lecture me about my lifestyle? And so many of them, it's kind of surprising to me. They're not open to even having that conversation. So I say, well, I'll be here for you for your next event, you know, and I'll see you then. And that's not universal, of course, but a lot of people are just not interested. And it's shocking to me. It's sort of surprising. Like, what is it going to take for you to turn things around? You know, and it's, you know, that's an individual question that I can't answer, but it's sometimes very surprising to me. I see men on their 4th and 5th heart attack that still haven't done anything, you know, other than take the drugs they were prescribed. They haven't lost weight. They haven't started exercising. They're still abusing methamphetamines in many cases. It's just crazy. It's crazy. So my men's health practice is like a breath of fresh air, you know, in some ways. If anything, those guys, I have to hold them back. Say, whoa, listen, you're doing too much. You need to, you know, it's okay to have a cheat meal once a month if you want to. So it's very different. Yeah, the two ends of the spectrum are very interesting.
Yeah. What were we going to say, Ross?
Yeah, I was just going to say similar to what you just said there, but I think as a medical professional, you know, being at the preventative side of things just makes more sense at a certain point.
Yeah.
You know what? If I could do, you know, if I got my hands on everybody and taught them what I know, we could prevent so many problems.
Absolutely.
So I think, yeah, a lot of us will naturally get to that point where you go, do you know what? I've enjoyed this, but I would love to just prevent all these problems.
Absolutely. Yeah, I'm busy enough in the emergency department. If I could minimize the amount of, you know, these complications of chronic medical conditions, that would be great.
How much do you, and I'll ask you this because you're at both ends of the spectrum in a sense, but how much do you think the patients attending the emergency department, because I felt this when I was in general practice, particularly towards the end, was that they rely on pharma too much. The concept that there'll always be pharmaceuticals to save my bad lifestyle.
Absolutely.
And rather, you know, and my message was always like, look, you know, most pharmaceutical, you know, I don't want to put a brand on everything, but most are sort of a plaster on this issue, a plaster on that issue, a plaster on this issue. Whereas actually, if you tackle the lifestyle and, you know, potentially hormones and other bits and bobs, that's the foundation. That's, you know, and so I think people have got this message. I'm not quite sure how, that they believe that big pharma will always be there to reverse what's happened. It's kind of
Absolutely.
like, if I have another heart attack, I'll get another stent. If I have another, this, I'll for my diabetes, there'll always be another drug for my diabetes. There'll always be another, and so that's where I got quite a lot of frustration from when I was in that area.
Oh, completely. Yeah. They vastly overestimate what in the emergency department, they vastly overestimate what I can do for them. And in all these cases, many times the horse has left the barn, so to speak, and they're sort of shocked when I tell them, yeah, I'm sorry, we're gonna have to amputate your foot. Like, they say, oh my, oh my God, how did this happen? I'm like, really? Do you not know? You really don't know how this happened? Okay. I don't know the reason for that. I mean, a lot of it is the fault of physicians, because first of all, what are we trained to do? We're trained to prescribe, for every problem, there's at least one drug, and many times, many others. And so, I don't know how much training you got in just nutrition and lifestyle in medical school, but I got zero, or it was just lip service. When in lectures on hypertension, they would say, well, obviously diet and lifestyle is first, and then that would be it. And if I were to ask them, well, what sort of diet, what sort of lifestyle, even the doctors don't know. I mean, doctors in the United States, I imagine it's universal. They're statistically looking at the data. They're only slightly more healthy than their patients, only slightly. They're just a reflection of the general population. So, they don't know anything about lifestyle or exercise or nutrition, and let alone hormones. And again, like you said, in a 10 or 15 minute appointment, how much time do you have to sit down and really talk to somebody about those sorts of things? Because you're absolutely right. We could cut the number of statin and antihypertensive prescriptions in this country probably in half, if not more, if that was our focus, instead of just on pharmaceuticals. Pharmaceuticals have their place, clearly. I mean, I prescribe them every day, but they really should only be prescribed when those other, the low-hanging fruit has been addressed, which is obviously diet, lifestyle. I'm very big on my practice in managing visceral body fat and reducing body fat. The average American male has something like 28% body fat, which is considered obese by our standards over here. And that's just the average. So, I mean,
I think it's 25. I think it's 25 over here. I think I remember. So we're a little bit behind, but we're getting there. We're behind you.
We're on the same trajectory. Yeah. And we're not going to a good place.
Yeah.
But that's the norm now, even though it's not normal, it is the norm. And so men can be sort of, I think, and women too, obviously, lulled into this false sense of security. Well, maybe I have a few extra pounds, but I'm not as fat as Bob over there in marketing, who's 300 pounds. Well, the truth is that even that extra 20 pounds of body fat that you're carrying, that has negative health implications. And if you were to get rid of that, you wouldn't need your statin medication. Perhaps you wouldn't need to be on blood pressure medicine, that sort of thing. So it's, there's no easy solution to this. Obviously, this is a global problem, and I don't know the best way to tackle it. If I had a solution, I'd have a Nobel Prize probably and be off on a tropical island.
Well, you mentioned about how, there's a couple of points there that's good to pick up on, because you mentioned about the nutrition training being lacking in medical training. Absolutely. But then even when you listen to the dietitians and things like that, sometimes you think that they're kind of off mark, really. Yeah. One thing that you're a big fan of, I know from your videos and things, is high protein. And I always talk about this sort of high protein intake. That's rarely mentioned in sort of modern medicine, I suppose would be the terminology to use. And then another thing you're big on isn't it? It's the resistance training. You talk about the sort of importance and significance of muscle mass, maintaining muscle. Yeah,
it's so important. It's so important. Yeah, well, and the protein thing is, when I'm sure maybe it was the same for you. When I was in medical school, there was the myth about you eat too much protein and it's going to put you into renal failure.
Yeah.
Which is clearly not the case. Even 4 people now that we know who have renal failure actually seem to do okay with extra protein. So yeah, absolutely. You know, protein intake is crucially important, especially if you're a resistance training athlete. But yeah, one of the things, I emphasize this in my practice, is that, you know, there's a window of opportunity for men and for women, obviously. And that window, it doesn't entirely shut, but it certainly becomes smaller after the age of 50. But prior to that, you have this opportunity to build skeletal muscle at an accelerated rate that you lose when you get into your 70s, obviously. And if there's one thing that will save your life, and just based on my prior experience, and not just in emergency medicine, but working in intensive care units, I mean, we've all seen the frail elderly person who is just holding on and able to live independently until they have just one little minor a little bump in the road. They get pneumonia, maybe they fall and they have a hip fracture. And really that's the end. They never live independently again. And 9 times out of 10, it's because they've lost that tiny little bit of reserve muscle strength, muscle tissue that was letting them get up off the couch and go to the bathroom, or get up out of bed, or get off the toilet. And now they're just too weak. And, you know, as you know, when you get older, once you lose it, it is so tough to get that back. So I think, you know, there's no better insurance policy for an older person. If you want to survive, you know, not only survive a critical illness, but then have any hope of returning to independent living, is you need to bank. You know, I tell patients it's like a savings account, your retirement account. If you have 20 to 30 pounds of excess muscle tissue that you can afford to lose in a crisis, it really behooves you to get that. And, you know, the earlier you start, the better. Obviously, I think the time to start is as a teenager. You should start lifting weights and trying to maximize your skeletal muscle tissue within reason and within the limits of your genetics as soon as you can. But, you know, it's never too late, but there really is a window of opportunity. And there's a quote that I love, and I wish I could remember where I first heard it because I could give them credit, but it said, if you want to be good at 80, you cannot afford to be average at age 50. So if you want to be the sort of 80 or 85-year-old that can go on a hike with their grandchildren, go on cruises with your wife, still have sex, and really enjoy those last, you know, 10 years of your life to the fullest, you cannot afford to be at least the average American 50-year-old who already is so far down that path that, you know, I know where they're going to be at 80. You know, modern medicine will probably keep them alive, but their quality of life is going to be terrible. I mean, that's what I see every day. I see 80-year-olds, they're institutionalized, they're in diapers, and they're suffering from dementia. And that's preventable, you know, that it's so sad for me to see that. And that's all I do. That's literally all I deal with. There's five nursing homes within a 20-mile radius of the hospital where I work. So that's all I see almost all day is septic geriatric people who, you know, with all these sort of preventable age-related issues. But the root cause of much of it is sarcopenia. It's loss of muscle tissue. So I hit that one very hard with my patients. I think it's very important. And there's a few other physicians out there on YouTube that say the same thing. I'm trying to think of her name. Gabrielle Lyons is very big on protein and muscle tissue. And I've watched a few of her videos. I don't know her personally, but everything she says, I'm like, yep, that's right. And that, you know, there was no information given on that in medical school for me or in residency, but it's something that I've observed just in my practice over the last 20 years is the people with more muscle tissue tend to be better. They tend to do better whenever they get a health crisis. So I'm sure, Max, you've probably seen the same thing. Yeah,
I mean, a big thing about they talk about hip fractures and things like that, and obviously, you know, barring the sort of big sort of systemic inflammatory response and things that can cause, I suppose, you get that muscle wasting, you know, and that again, like you said, the quality of life pre and post can be so dramatically different if someone has that borderline sarcopenic physique already. You know, they're just tilted over the edge in all these conditions. Yeah.
Yep. It doesn't take much to sort of put them over the edge. You know? And then they're in the hospital, they get a DVT or PE, they get pneumonia, they get urosepsis, and that's it.
So for your guys, say the average patient, you know, your average prevention clinic comes in. Is there like a set of things that is quite similar for everybody that you advise? Is it, you know, obviously they'll be individualized. Yeah.
I mean, you know, there's, again, I call it the low hanging fruit. You know, what is the number one killer of men worldwide? It's cardiovascular disease. So I take a long, hard look at all of their cardiovascular risk factors. We try to optimize those. And, you know, obviously lipids are part of that, but there's a lot more to cardiovascular disease than just someone's lipids. You know, it's you know, cardiovascular disease and cancer are the two things that kill the majority of men. And so that is the low hanging fruit that I address with all men. And then, you know, after that, it really depends on, you know, what they bring to the table, their family history. I have a fair number of guys who are diabetic and in the pre-diabetic range. And my goal is to reverse that entirely, if possible. And many of them are surprised to even hear. They've never heard a doctor say that you don't have to be a type 2 diabetic. I mean, they're under the impression that they will remain a diabetic for the rest of their life. And certainly there comes a point, you know, where the beta cells completely fail, and it may not be reversible, but most men with type 2 diabetes, women too, it's reversible. So, you know, if that's something that we work on very heavily, if that's not an issue, sometimes it's libido, it's sexual function. So it's not a cookie cutter approach, but it is the cardiovascular part of it is something I address with everybody right off the gate, because I don't care if you have a 1200 testosterone and a 6-pack and 5% body fat. If you keel over from an MI at 60, I probably haven't done my job very well, you know. So
where's the testosterone come into the preventative side of things? Is it purely sort of because obviously you speak to different people from America. We spoke to Dr. Grant quite recently, and he was talking about, and obviously everyone differs a little bit, but symptoms being king. You know, you look at the bloods, but you know, because you've got a similar issue. I say issue, where the endocrinology societies and things like that, they have a line in the sand, don't they?
Yeah.
And I think in America it's like 250 or 300. Obviously, it's a different unit that we tend to use. Over here, it's kind of 8 or 12. But depending on which guideline you look at. Yeah, exactly. Yeah, exactly. You know, I was obviously fairly delayed in going on TRT, I would say, but certainly had symptoms at 14. Got down to 7.8, and at that point I was having like hot flushes and things like that as well. So I was kind of like, give me the whole host here, mostly, you know. So yeah, in my opinion, you know, we're kind of quite. So I presume we kind of like to say there's a sort of symptoms are not necessarily king, but you've got to look at the symptoms before you even open up the lab work and see what you're dealing with. And so, yeah, just your
I agree completely. I again, I don't know Dr. Grant, but I've watched a few of his YouTube videos, and again, everything that comes out of that guy's mouth, I'm like, yep. You know, he's absolutely correct about it. Let me say something just quickly about guidelines. You know, I don't have a problem with these endocrine society and urological guidelines out there, but I think it's really important, not just for patients, but for physicians, especially to realize that, you know, guidelines are what they are called. They're guidelines. This is not holy writ, right? This is not sacred scripture. And I'll use, you know, there are guidelines in all of the medical specialties out there, but, you know, a good example is the ATLS guidelines. So advanced trauma life support, advanced cardiac life support, ACLS, you know, guidelines. So that, you know, the ATLS guidelines were created by an orthopedic surgeon who was horrified by the terrible care that his family received. I think they were in a plane crash, and they were at a small rural emergency department managed by GPs and family physicians. And I think this may have been like in the 70s or 80s. And, you know, he was just like horrified by the terrible care that his family received. So he said, I'm going to do something about this. And so this ATLS course and the guidelines all came about. And the purpose of those guidelines, just like ACLS, is to give a pathway for physicians who don't take care of trauma on a regular basis, to give them, a safe path to follow. If you just follow this guideline, you're probably not going to get yourself in trouble, and you'll probably do an okay job taking care of people. So it's important that, the ATLS guidelines were not made for trauma surgeons. They were not made for emergency physicians. They were not made for people who are experts in the care of trauma. And ACLS guidelines as well were not made for cardiologists. Cardiologists don't need to be ACLS certified, but the hospitals still make them. I don't need to be ACLS certified. I deal with cardiovascular disease every single day. I defibrillated somebody less than 48 hours ago. I do it every single day, but the ACLS guidelines are for the GP, the pediatrician, maybe the urologist, or somebody who just, they need a safe pathway. And that's how I think about the endocrine guidelines as well. They are for the family physician. They're for the provider out there who does not take care, who's not an expert in testosterone replacement therapy. And it gives them a nice, safe path. If you just stay on this path, you won't get yourself in trouble. Everything will be okay. But they're not meant for people like us that have been doing this for 20 years. And they shouldn't be for endocrinologists either. I mean, they are hormone experts. They do, what I think is a 2 or 3 year fellowship in this sort of stuff. So let me that's what I want to say about guidelines. They are recommendations.
Mm-hmm.
Okay? The problem is, of course, is that, again, they get treated like holy writ. And I've heard endocrinologists say this, that, if you're above, whatever the arbitrary cutoff is, well, you don't qualify for treatment, regardless of the fact that, you have all of these symptoms. And we can't find, and we've done a proper history and physical exam. We're not finding any alternative diagnosis. And the implication is that, we can just use 250 as a cutoff. Well, if you're 255, then there's no possibility that you would benefit from testosterone. And that's not true, obviously not true, right? Obviously not true. So my approach to this is, I know the guidelines backwards and forwards, but I am much more interested in symptoms. But I'm also, I also look at somebody and I say, do you have one or more chronic medical conditions that would stand to benefit from a higher testosterone level? So, you could have a testosterone level of, we'll just say a total of 450. And, perhaps you are symptomatic from that, but you have uncontrolled type 2 diabetes and you're on three drugs. And, maybe my next option is to put you on insulin, which I would prefer not to do. Well, we know that, that optimizing a man's testosterone will absolutely lower their hemoglobin A1C. It's going to lower their cardiovascular risk. It will do nothing but benefit them from the standpoint of their diabetes. But that's nowhere in the guidelines. No, to my knowledge, it's if it is, it's just sort of like a one-liner afterthought. So, there's good data that testosterone supplementation improves heart failure symptoms. So why should it not be considered as an adjunct in addition to all the standard therapy that we give to people with testosterone or with heart failure? Why not consider testosterone? It's cheap, it's inexpensive, it's safe, as we all know, especially when it's managed by a physician who understands it. There's a testosterone I call it testosterone phobia in the general medical world. And I think it probably comes from the bodybuilding, anabolic steroid world. And it's just, and partially just due to physician ignorance. You and I both still hear about primary care doctors telling people that testosterone is going to give you a heart attack and it's going to cause prostate cancer. And it's just, I sort of just think like, well, how many more papers do we need showing you that, one, that is not true, and it's actually the opposite? I mean, how many more? How many more do we need? I don't know. We already have hundreds.
Yeah.
So
those papers have been put into big papers that have looked at all of them.
Oh, yeah, the meta-analysis. Things, I don't need to tell you guys, but things change very slowly in medicine.
Yeah.
So maybe one day we'll get there. But just to circle back, I mean, I agree with Dr. Grant. Symptoms are king. It's not that numbers are irrelevant, but they are not a good reflection of what's happening inside the cell necessarily. We know that there are variations in the androgen receptor that are genetic. We know that there are epigenetic factors involved. There are I'm very interested in endocrine disrupting compounds and the effect that that's having. We know that there are hundreds of them that interact with the androgen receptor and impede its function. So, that's what matters to me ultimately is their symptoms. And if they have another medical condition that would potentially benefit from testosterone, then that's even more incentive for me to consider it. Assuming I've done a proper workup. I think that's really important to say. A lot of men, again, this is what drives me crazy about these clinics here in town, is they will diagnose a man with low testosterone, but they many times they don't even do the basic workup to find out why. They'll get a prolactin just because they're supposed to, but they don't know what to do with that necessarily, and they don't even check to see if they have a varicocele or a seminoma or liver disease. The very first man I ever diagnosed with low testosterone as an intern in family medicine, I'd been a doctor for about 4 months, had a profoundly low testosterone. He had hemochromatosis, advanced hemochromatosis, and severe liver disease. And nobody had ever found it, but I found it by chasing his low testosterone levels because I didn't know what I was doing, but I had an attending that made me order at least some of the more appropriate labs, and took me a while, but I've ultimately made that diagnosis. So I will throw that out there for the listeners, is just make sure that your doctor has explained to you why you have low testosterone, if they can find a reason. A lot of times it's idiopathic, as you know. We don't always have a reason, but at least let's take the bad things off the list first. I don't think a man should walk out of a TRT clinic with a prescription for testosterone after their first visit, which does happen, unfortunately. So that's just my take on it. Yeah.
Where do SARMs and things fit into this?
Oh, great question.
Because they seem to have nowhere, and you go online and there's just hundreds and hundreds of sites that sell them, and they sound like this holy grail of health, but I'm thinking they're not. But I'd love to go to get
SARMs. I am the focus of my medical practice is on long-term health and longevity. So when you look at them from that perspective, I don't think that they offer anything in that regard. And having, with the caveat, of course, that we don't have a ton of research on these substances, many of them, I consider them to be sort of their failed big pharma drugs, where they, some of them are still being investigated to see if there's some sort of way that they can be used clinically. But many of them, they made it through a phase 1 or a phase 2 trial and then were abandoned because of side effects or for whatever reason, that just these were not going to be viable drugs. Many of them had liver toxicity. I have seen them do some pretty unfavorable things to people's lipids. I don't think that they offer a man anything that testosterone can't. Basically, everything that SARMs do, testosterone does better. Now, I'm not talking about the bodybuilding world, and there are guys that may want to use them for performance enhancing benefits, and obviously they're in this sort of legal gray space here in the States. I'm not sure how they're treated in the UK. They're readily available here, but it bothers me that there's high school students taking this stuff, and we don't know what does that do to a 15-year-old boy? How is that going to impact his development? Not just of his physical development, but his cognitive development. And we know that testosterone and the metabolites of testosterone are crucially important for brain development, and in particular the frontal lobe. Nobody knows. And then the final thing that worries me about these things is, there's no regulatory oversight about how these things are manufactured and the purity. There's a number of studies out there showing that a lot of these compounds don't have what's on the bottle. Some of them do, some of them don't. Some of them have nothing at all. I think at least half of them I saw have some other additional compound that's not on the label. So, somebody could be making these in their bathtub at home. And so, there's obviously concerns there. So I try to steer guys away from SARMs. Max, I don't know how you feel about it. I just, from my perspective as a physician, again, looking at longevity and overall health, I have yet to find a use case for a SARM. Now, peptides there's peptides that's different, but SARMs, I don't know. How do you feel about it, Max?
Yeah, I think you're right. I think there's just not enough about it, really. It's one of those things where, we're talking about testosterone having a lot of studies, but and then you're using the theory behind it. But the SARMs, there's just, there's a couple of rat studies. There's, and then there's one that's, a couple of case studies on, liver damage to people who presented to hospital and things like that. So, I don't think there's enough there to, really go off. And like you said, it's kind of like to a lot of the guys out there, maybe it's different in the teenagers and things like that, which just seems like crazy. But the older guys, it's like you said, well, what about healthy testosterone levels? What about a decent dose of TRT? I don't know what part of the market they really would hit logically at this point, because of the lack of, we've got a lot of data on other stuff that works nicely, I suppose, is how I would look at it.
Yeah, I read a paper once, and they were it was talking about sort of the history of SARMs and sort of where are they now, where do they come from, and they said the justification for pharmaceutical companies to develop these drugs was that they wanted the anabolic properties of testosterone without the adverse cardiovascular problems associated with testosterone. And the first thing I said was, well, what adverse cardiovascular? What are you talking about? So the very premise for the development of these drugs, they're built on a false premise that testosterone is dangerous.
Yeah.
And maybe as time goes on, we realize that testosterone clearly is not dangerous, especially when it's managed appropriately. So now there really is no use case for SARMs, because these negative testosterone effects that you were trying to avoid don't really exist. Makes sense. I would much rather, if grandpa comes in with sarcopenia, which many of these SARMs were developed for the treatment of sarcopenia, I would put grandpa on testosterone 99 times out of 100 over at choosing a SARM. In fact, probably 9,999 times over a SARM. Because I know that he stands to benefit from that. There's a mountain of literature showing that there's potential benefit, that the downside is so small when it's done appropriately. But I don't have that pile of data for SARMs. In fact, I have a lot of data that says it might not be a good thing for grandpa to be on a SARM. So, yeah, I think SARMs will eventually kind of go away. At least kind of I'm hoping they will. But I don't know.
They kind of fall into the same area as peptides in the UK, in that they're all just called research chemicals.
Precisely.
And that's how people get around it. But they're so easily obtainable. There's just websites everywhere. And it's a shame that they are grouped together with the peptides, where there is a lot of compelling evidence to back those up.
Absolutely. Yeah. And it's the same in the States with peptides. Now, the FDA has basically said that they're not going to allow compounding pharmacies to produce these anymore for reasons that I don't want to get into. But so that will just drive things underground. I mean, that's basic capitalism, the laws of supply and demand. And I, the same concerns I have with SARMs are obviously the same concerns with peptides. Is, again, you don't know the source, and they may provide a lot of the peptide sites will have a certificate of authenticity that has, says this is 99% pure, and maybe that is true. But I could Photoshop that. I could make a very convincing on my computer here. I could make a very convincing sheet of paper that said exactly the same thing. So there's no regulatory oversight, but SARMs and peptides do unfortunately get lumped together. They're not the same thing. I'm cautiously optimistic about the future of peptides. I think that there's a lot of potential there. again, I'm a bit of a data guy, so I just would like to see a lot more human studies, and rather than the FDA sort of putting the hammer down and stopping the legitimate manufacture and prescription of these compounds, I would much prefer them to perhaps fund more studies, so that, because their justification is, and it says in their press release, may be harmful. Well, okay, let's answer that question. Let's do the studies. Mm-hmm. But that's not their way of resolving the issue. Their way of resolving the issue is to legally, prevent their manufacture by legitimate sources. So anyway, I'm optimistic for peptides. I think that there's more likely to be a good clinical role for the various peptides than there is for SARMs. I just want the data. I just want studies, I'm fairly conservative in my practice. I mean, in the men's health space, I'm kind of a bit of a goody two shoes in that I really, if I'm going to prescribe something to a patient, I would love to have a strong evidence base. And if I don't, but I still think it would benefit them, I'll try to sit down and have that conversation with the patient and not promise things that I can't deliver, which I do see. There's a lot of physicians and other clinical folks in the peptide space that I think exaggerate what peptides can do for people without perhaps having the literature support for it. So, I would like to see more data. That's just me. But SARMs, I don't think there's much of a future. Peptides, I think that there is. We just need the studies.
Well, you can get a hell of a lot out of testosterone and lifestyle changes, can't you? That's the thing, isn't it? You don't necessarily need to go down these routes necessarily. If you get with a decent TRT, structure and a good lifestyle intervention, a lot of that can go a long way, can't it?
Oh, absolutely. Yeah, absolutely. I mean, that almost goes without saying that. And I've noticed this a lot on TRT forums and just in talking to patients that, there are guys that it's almost like a hobby for them. They're just super interested in whatever the latest peptide is and the dosing this and tweaking this. They're trying to be amateur endocrinologists. But when you talk to them, they don't have a clue about how to train. They don't have a clue about nutrition, but they love the minutia of these peptides and the testosterone and I'm adding pregnenolone and DHEA and I'm going to tweak my progesterone a little bit. And meanwhile, I look at their profile picture and they're like 40 kilos overweight. I think I might know what your problem is. And it's not your pregnenolone level.
Yeah.
So
do the GLP-1 agonist fit into your clinic then, especially thinking about that guy that's 40 kilos?
Yeah, on a case-by-case basis. So these are really, in some cases, kind of miraculous drugs, but in my opinion, they're used inappropriately. They're so popular because they work. So of course, you're going to have clinics that want to provide these for a fee, which is usually pretty high. But the big mistake I think that they make, and it's a huge disservice to patients, is they don't provide the infrastructure, the education along with the drug. Because ultimately what these drugs do, as we all know, they allow you to maintain a calorie deficit, and they just make that whole process less painful. They slow gastric emptying, they affect satiety centers in the brain and food craving, so you eat less calories. Well, it's not surprising that if you eat less calories and of course you don't manage your protein intake, you're not engaged in resistance training, you're going to lose a substantial amount of muscle tissue as you lose that. You're losing weight, but maybe a quarter to a third of that is muscle tissue. So that is a huge disservice to the patient, in my opinion. And the conspiracy theorist in me is sort of like, well, that's part of your business model, because that now you've sort of metabolically wrecked these people and they're going to gain the weight back. It was like these phentermine clinics that were popping up all over in Florida when I lived in Florida. And there were these, phentermine weight loss clinics, and they put people on 800 calorie a day diets. They lost a ton of weight because they weren't hungry on phentermine. And of course they gained it all back again. Because they never learned how to eat. they never learned to, or they never addressed, some of the psychological issues that lead people to overeat. A lot of people have, background trauma, and they use food. They don't eat because they're hungry, but they eat for other reasons that are psychological, and those never get addressed. So I love GLP-1s. I think when they're prescribed appropriately in the setting of a comprehensive weight loss, and I don't even call it weight loss, like a body recomposition program, they can be a really helpful adjunct. And especially if somebody is suffering from, if hyperglycemia and type 2 diabetes, and they need to get that weight off, and they need to get that body fat off as quickly as possible, they can really help with that. But I just worry that, and I've seen this many times, it's just patients they're given their prescription and there's no support at all. And then they're going to be back.
I think that's the first video. That's where I introduced Ross to your work, was a video on GLP-1 agonists. Yeah. I sent it to him. I said, check this out. Yeah, I remember that. Absolutely. Yeah.
So I guess the short answer to your question, Ross, is I do use them. But again, I have lengthy conversations with my patients about how we're going to use this, the length of time we're going to use this, and the way that we're going to get you from point A to point B safely. And, my goal is that you only need to use these drugs once, because you get to whatever your goal composition is, and then you don't need them ever again.
And you got to keep
unless
that,
unless there's a medical indication.
You've got to keep that muscle, haven't you? Yeah.
Sorry?
You've got to keep that muscle when you're losing the weight.
That's the key. Yeah. That is really the key. It is the major. If you look at all the things that contribute to basal metabolic rate, it's muscle tissue is the number one. The number one thing. So you really have to preserve that, and of course that's where the protein comes in. I recommend as a minimum of like 2.2 roughly grams per kilo for most adults. For elderly people, it's more. Yeah, that may need to be up to 3, and that's an evidence-based recommendation. I didn't just pull that out of where. It's that's an evidence-based recommendation. But what happens to old people? Do they eat more protein on average? They end up eating less, and it just makes everything worse. So,
yeah, 100%. Well, it's been an incredibly enlightening conversation. We've skipped around a bunch of subjects, but I've absolutely loved every minute. Any nuggets of information to leave for our listeners? And also, if someone's listening and they're like, I really want to work with Dr. Winge, how do they contact you? Where do they find you?
Sure. Yeah. Final pearls. It's not going to be anything profound. It's probably not anything people haven't heard before, but the information is out there. Educate yourself on how to eat properly. You have to do resistance training, in my opinion. That doesn't mean you have to be a bodybuilder, but you need it, especially as a man. You have to engage in resistance training. The more muscle tissue you put on before the age of 50, the better. And certainly don't shy away from considering testosterone therapy if you feel like you're developing symptoms of low testosterone. Do your homework, read about it. Become an educated patient. Especially once you're on testosterone therapy, don't rely just on your doctor to just sort of dictate to you from on high how you need to manage your health. I tell my guys, and even in the emergency room, your health is your responsibility. So, you have this thing called a cell phone that is more powerful than the computer that took the Apollo astronauts to the moon, and you have access to all knowledge ever created by the entire human race can be accessed through this phone. So, don't look at cat videos. Go use it to educate yourself. I guess, so that would be my advice. And if people want to get a hold of me, they can go to my website. It's just manmedicine.com. I have a contact form there. You can email me. Men from all over the world, like I said, email me all the time. I love to have conversations with guys and do what I can to help them. So, feel free to reach out if there's anything that you think I can do to help you. I'd be happy to do it.
Wonderful. Thank you both very much. I shall let you get back to your day.
Thank you both. Yeah.
Thanks, Andrew.
Yeah, let's do it again sometime.
Definitely.
100%.
Thank you for listening to the Alphagenix Podcast. Make sure to subscribe to the channel so you don't miss next week's episode. For more resources on Alphagenix and men's health, visit alphagenix.co.uk. Until next time.